This episode is part of our Better Ways of Knowing mini-series, which we're running on this feed throughout the summer. The Better Ways of Knowing project asks how we should produce, evaluate, and act on knowledge if the goal is to continue to improve the health of populations. And in this series, we're sitting down with people who were part of our first convening to hear their reflections on that question. My guest today is Dr. Kumanan Rasanathan. Kumanan is the Executive Director of the Alliance for Health Policy and Systems Research, hosted at the World Health Organization in Geneva, and a partner on this initiative, leading the global learning component in 4 low- and middle-income countries. He's a public health physician whose career has run through clinical trials, frontline pandemic response, and global health policy, which makes him a guest who has worked at nearly every point in the knowledge production system we are trying to understand. In this conversation, we get into what strikes him about how these systems were built and who they were built for, what the Alliance does, why the global learning components of this project matters, and how AI is likely to reshape universities and healthcare in the years ahead. Here's our conversation. Kumanan, welcome to the podcast.
Pleasure to be here, Salma.
So during the convening, you moderated one of the earlier sessions because we thought you'll just be the perfect person to lead this because you've worked through the entire knowledge production system. So you moderated a session about how knowledge is produced, who funds it, who credentialize it, who ranks it, whose knowledge is credited versus not. So if you step back, just looking at your entire career, but also some of the lessons we had from the convening, what strikes you the most about how we build knowledge systems and who we build knowledge systems for in public health and in global health in general?
The convening was such a pleasure to visit you and be with you at St. Louis and see what you're building from an already strong foundation. I think the convening really brought together a lot of very interesting perspectives. But for me, reflecting on how we built our knowledge systems, on the one hand, so much has been achieved. I mean, clearly, over the last century in particular, there's a lot more knowledge on how to improve health, how to protect health, how to promote health. And that has translated to unprecedented gains in human health and in life expectancy. If you look at the life expectancy graph for most of human history, it's relatively flat or the slow improvement. And then we've just had this huge acceleration in the last century. So clearly, and knowledge systems have contributed a lot to that. So clearly, many things have gone right. At the same time, I think the convening distilled very well what types of knowledge we have privileged and prioritized, and what have been the limitations of the types of knowledge that perhaps we haven't valued. The convening also highlighted whom we have privileged in the generation and the sharing of knowledge. And again, perhaps what we have missed out on by excluding some people, right? And what I would say is that I always joke that perhaps the university and the hospital are the most conservative institutions in our society. They're very high status, but in many ways their fundamental fall has not changed over decades, if not over centuries. And most other things in our society have been fundamentally reshaped, certainly in my lifetime.
Yeah.
And so I think that's my reflection, that there's much that we've done well, but given we're in an era where the world is changing so rapidly, given there's such fissures, such concern over inequality, that knowledge systems cannot rest on their laurels. We are being challenged in a way perhaps that we haven't been challenged for a long time. And so given that there will be some reshaping, there's a tremendous opportunity to preserve the value of our knowledge systems, but also address those gaps in terms of what types of knowledge have we neglected and who have we neglected in the generation of knowledge to improve health.
I actually want you to tell a story that you told during convening, if that's okay, because I think anyone who listens to you right now or reads about your CV or what you're doing right now would think you really focus on applied work. you are someone who, as we talk right now, you're thinking a lot about different types of knowledge. So clearly you haven't really been part of a rigorous scientific process. That's why you're coming from this perspective of, we need to expand what we mean by knowledge systems. But I think you provided a really important perspective during the convening, speaking about your experience as someone who was part of a clinical trial in New Zealand. So can you walk us a bit through that and help us explain, as someone who's seen what RCTs do on the ground, why are you right now interested in expanding the knowledge production system?
Well, I don't need that much encouragement to talk about that experience. I would say that in my career, and perhaps what I'm more known for, I have enjoyed thinking about big picture issues, social determinants of health, primary health care, types of research, like implementation research. But I will say that probably two of the most satisfying experiences in my career were, one, as you say, working on randomized control trials to provide safety and efficacy and immunogenicity data for a new meningococcal vaccine to enable licensure and then roll out to children in New Zealand. And that was 25 years ago. And then the other, which I think also is relevant, is my time as incident manager for WHO at the beginning of the COVID-19 pandemic in Cambodia. And I suspect they are two experiences that most people don't necessarily associate with me, given my role now and some of the other roles I've had. But the story that you've heard and that I've often told is that I was a young man and New Zealand had a bad meningococcal B epidemic, profoundly unequal, concentrated in Maori and Pacifica children, in adverse social determinants, strong associations, as you may know, with meningococcal disease, with overcrowding, with poor housing. And the government decided to fund trials and vaccine rollout, if the trial was successful, for a new meningococcal B vaccine, because for this strain that was dominant in this New Zealand outbreak, there wasn't an existing vaccine. There were vaccines for other meningococcal B strains. And so I was recruited slightly accidentally. It was a serendipitous occasion to be one of the study physicians and trial leads, and I worked on several phase 1, 2, and phase 2, 3 trials. The phase 1 studies were in adults. The phase 2, 3 studies were community-driven studies in children in the communities that were most affected by the epidemic. And it was a very rewarding and challenging experience. I didn't know so much about clinical trials before this, so I had to learn a lot early on. And I think what you're alluding to, you want me to share, is that I both worked on the development of the data in the clinical trials, but then later on, I worked in a primary care organization and I saw the rollout and helped inform the rollout of the vaccine. And what has always struck me is that how different those settings were. This is in a high-income, relatively good governance country with a lot of resources, and yet with deep inequalities, and we were having high rates of this disease and high rates of mortality. And they were like on different planets. The experience of being a study physician in a randomized control trial where anyone who, in this case, we did so much outreach with the communities. We really saw the pride that young people in the community had in volunteering for the trials. These were publicly funded, public benefit studies, although we worked with a vaccine company to produce the vaccine because New Zealand didn't have the biotech capacity at that stage to do so. But that clinical setting in the trial was so different to any clinical setting you have normally, right? So any concerns that anyone had in a trial, they could get access to me or another physician 24 hours a day. The level of outreach they had, that the trial participants had with doctors, with nurses, with community workers, very, very high engagement. And then when you compare it to the clinical setting, where we did do a lot of outreach for the rollout, but much less access that people had for their fears or their concerns. And my learning from that was randomized control trials are very important. They have their place. They provide evidence of potential efficacy, of safety, of immunogenicity. But you cannot say that because something works in a randomized controlled trial, it's going to work in your specific real-world setting, because those settings are so different. And I've really thought about that over the last 25 years, because we often don't appreciate that nuance. We often treat randomized controlled trial evidence as the gold standard that will predict effect size or impact in real communities. And yet, That is not what randomized control trials are designed to do. They're designed to answer a specific question, but they're not designed to assess what will be the impact of this medicine or this intervention in a real world population. And to do that, then I would say you need to do the sort of work that I work on now, the applied research, the policy research, the implementation research, to understand how the what then translate to the how, right? And to bridge what we call that no-do gap.
Yeah. So I want to get into the work that you're doing at the Alliance, but also in collaboration with this Better Ways of Knowing meetings, thinking about what type of research is needed to inform some of the work in the US. But before we do that, why can't the answer be, well, if countries just recreate the RCT setting, like what you just described from the randomized control trial in New Zealand, that was excellent, providing that much support to participants. If countries just do that the right way, wouldn't we get the effect size? Why can't we just do randomized control trials very well and then get countries / private entities to just replicate that at scale? Wouldn't we solve all the problems we have?
It's a great question. I think the answer lies in the cost of randomized control trials, right? Randomized clinical trials. They're extremely expensive. I mean, this is why the pharmaceutical industry justifies the cost of many of these new medications, because they are very expensive. They cost, millions of dollars, tens of millions of dollars, and take time. Although the time frame for randomized control trials has been reduced with some of our new technologies, right? And certainly during COVID-19, we saw what was possible in terms of rapid RCTs. So in an ideal world, yes. But let me qualify that. Would that be the ideal world? There is an opportunity cost for all resources we spend, right? Often in the health sector, we just sometimes are called health imperialists. Health is all that matters. We should spend as much as required because of the right to health. But the reality is that we should challenge scarcity narratives when perhaps they're used cynically. But it is true that societies have a set amount of resources at a given time, and they need to make choices on how they use these resources. And it would be inefficient to have that level of support and engagement, right? And certainly in a world that lacks 10, 11 million health workers, certainly unfeasible, right? So I think that is the answer. But as I said, I'm not really sure that level of intervention would be right, because I think when people sign up to clinical trials, they're signing full form consent form. They're a selected population that agrees that they want to spend so much time in terms of a clinical intervention. But I don't think, regardless of the money, I don't think people in their everyday lives want this much engagement with the health sector for them to access services. Right. So I think there are costs, yes, to society and the financial cost, but there are time costs. There are other costs to people if every health intervention required that level of engagement. And I think people would not accept that.
And I think just real life also is just way more complex that we can, we're able to capture it. Yeah.
Exactly. We couldn't model all of the social factors, all of the social determinants in a clinical trial. And of course, especially given part of the reason you provide so much support in an RCT is because you're trying to standardize the experience and avoid bias so you can get an answer on the items of interest, on the questions of interest, right? So you do want to know, for example, does this vaccine provoke an immune response, right? Yeah. So you try to eliminate other sorts of bias, many of which are in the social determinants, right? So it just wouldn't be practical.
Yeah. So, and I want to go back later. I actually have a question for you. I don't want to forget it. Whether you think AI will solve all of those problems. I think you and I had interesting conversations about what AI could do for the future of university and healthcare, but we'll get back to that later. What I want to talk about right now is really the work that the Alliance does, just in general, and then maybe specifically focus on the global learning component of this project that you and the Alliance are leading. But let's start with telling us a bit about what is the Alliance, what do you do, and why is it important to be partnered with WHO to do the work that you're doing?
So we're the Alliance for Health Policy and Systems Research, which is a name that people struggle to remember. It's very much a name from the 1990s. So it was formed in 1999, and its essential mission hasn't changed. It came out of a 1996 WHO report on health research, which identified that applied research, implementation research, policy research was neglected in most countries. The capacity was very limited in most countries. And yet such types of research are essential to close the so-called no-do gap. And just for listeners who haven't heard that phrase, penicillin was invented in 1928. Amoxicillin was invented or finalized, formulated in 1968. And now amoxicillin, a dose costs less than $1. And yet almost 700,000 children under the age of 5 still die of pneumonia every year. Most of those deaths could be prevented by effective diagnosis and treatment at the right time with amoxicillin. So we talk about all these new technologies, and yet something cheap and simple and life-saving that we've known about for decades, we still cannot get to enough children to prevent hundreds of thousands of deaths. And that is the no-do gap, right? And that is to our shame. It's not easy, but we need to do better. And so our type of research is very much health policy system research is how do you close that no-do gap? How, when you have the evidence that an intervention or a policy works, often from an RCT, how do you actually ensure that it's delivered effectively, and why is it not being delivered effectively? And so that's what the Alliance does. And we do 3 things. We support high quality research in low and middle income countries. We support, and then the use of that research, we support building institutional and strengthening institutional capacity in low and middle income countries. And then we advocate for the field and help to build the field in types of methods. And that's what we've done for almost 30 years. And that's still relevant. But of course, the world is very different. And you were in Geneva recently for the World Health Assembly. One of the main streams of conversation was the so-called global health architecture reform, given the crisis that global health is in. And one of the things I think that I said to you was we need ourselves. We cannot be immune to that. We still have a niche. We're still quite stable. But we need to rethink what is the Alliance's role going forward.
Yeah. So then coming to the global learning component of this work, because of what you said, the Alliance really focuses on applied work. And given what you said about being in a moment of change, really, hopefully for the better, you have decided to lead the work of this initiative in 4 countries. The work is going to focus on places that do research differently to impact health outcomes. And the hope there that not only do we learn from those countries, but we learn in a way that could impact practice in the US. So what do you mean by doing research differently? What does that mean in a practical sense? And how are you envisioning this global learning component of the work?
So the genesis of this work is quite a good story and quite a long story, actually. Yeah. So during the COVID-19 pandemic, as I said, I had this very intense experience being the incident manager for COVID-19 for WHO in Cambodia at the beginning of the pandemic, and I worked there in 2020. And that raised a lot of questions. And as I said, that was another, other than the meningococcal experience, that made me reflect a lot on the role of research, the role of learning in acute and challenging situations. I will tell you that I wasn't thinking a lot about research in the first few weeks of 2020. Right. I was focusing on getting treatment guidelines, protocols, training people, working with multiple partners, sourcing equipment. But of course, all of our response was a sort of tacit learning. Right. Yeah. So we had this experience where it was a new organism. We could bridge to previous experiences with respiratory illness and the organisms that cause those, but it was new. And so in real time, we had to learn from each other. There were a few very good papers. I mean, Gabriel and colleagues had a very important paper at the end of January 2020 in the Lancet. But overall, there was a lot of information, but it was hard to know what was useful and what was not. And a lot of the information wasn't necessarily from people in the front line dealing with the challenges, right? But what we had was on messaging platforms. We were sharing, we were learning, we were trying things, and we were exchanging. And that, I suppose, in a way, also made me question, are our formal knowledge systems fit for purpose, right? Because I think they really struggled in those first few months to be the key agents. I don't think it was the formal academy that was the most useful, with a few exceptions. But it was practitioners sharing, testing, talking, and really coming together as the world to try and support each other when we're all faced with this incredibly challenging situation. out of that sort of impulse, I started having some conversations with the Robert Wood Johnson Foundation, in particular with Alonzo Plow, who's the Chief Science Officer at the Robert Wood Johnson Foundation. And we were reflecting on exactly that. We were thinking on what, and especially as we saw some of the negative and unintended consequences for health equity in COVID. The fact that there wasn't enough attention to the social determinants of health. There were these huge inequities in access to countermeasures, obviously access to vaccines, but also people's ability to adhere with public health and social measures. I think you have captured that with your community in St. Louis so well. I was so thrilled to see that publication. And that made us reflect on, again, whose knowledge counts, what types of knowledge count, what are we missing? After that, when I joined the Alliance, we continued that conversation. And as you know, we then linked up as well with you and with Sandro. You were at Boston University then. And then we had this meeting in late 2024 on equity and different ways of knowing. Right? And a lot that in that discussion, and we had both American participants and we had global participants. And it was a very interesting meeting. It was a challenging meeting. It was not easy, right? People reflected on the challenges they faced. It was a very personal meeting. But out of that, then, as you remember, Sandra and I, with you and Robert and others, we talked more with Alonzo. And we thought, well, maybe we can do something. I think Alonzo really appreciated bridging the American experience with the global experience. And I really sort of congratulate him for that. And we thought, well, could we do something together that thought of different ways of knowing to address these gaps, which are very evident in that meeting? But also, could we learn from each other? And of course, then normally Robert Wood Johnson funds domestic American work. And of course, you and Sandra were the best people to lead on that. But he was really interested in saying, well, what are other people doing? What are we doing, particularly on the role of community and civil society in generating knowledge, where social movements are generating knowledge to overcome health obstacles, to improve health equity, and could we then bridge those experiences? And so that's what we're doing with his support and with the support of the foundation. You launched the initiative at the meeting at St. Louis, and then we have now selected the groups that we will work with in 4 countries, which we're very excited about. And the aim is to bring it all together. And I think what this initiative shows is this appetite people have, not just to talk to the people they know, whether that's not just talking to the people in their own country, whether that's not just talking to the people who are in the institutions that you work with, right? And so it's a little bit of an experiment to see what can we get out of bringing these different perspectives around different ways that knowledge systems need to work to produce actionable knowledge to improve health equity.
So I have to say, as someone who's from Sudan and has been in the US for a few years now, this is quietly radical. I'm waiting to see the results of this experiment, because we just think of global health as like you do something in a high income country and then you try to do implementation science in a low middle income country for the same solution. So I'm very much interested to see what happens when we present people with a global solution and tell them, oh, you can do this here in the US. I don't know if you have any guesses on how that goes. I've been thinking about this for a while, because it makes sense. It's obvious. You learn from different settings, but I don't know if, despite all the slogans and all the things we say, if people are ready to say, oh, a high income country could learn from a low or middle income country. Any thoughts on that?
Well, you're the one in the US, you're the one at American University. And so if you tell me it's radical, I will defer to you. But I think it's very practical. I think it's really we need knowledge that works, and we should be humble about seeking that knowledge wherever you can get it. I always joke, and I've made this joke. It was actually a joke. I always slightly complained jokingly that in Cambodia in 2020, that whenever I had a question, I just emailed everybody I knew on the planet and said, can you help me? And I didn't care where they were from. Right. And I didn't necessarily, because it was an emergency situation, follow all the usual protocols and gatekeeping. But I just wanted an answer. I didn't have any time. My colleagues didn't have any time. My small role was to support the Cambodians, who were working incredibly hard and very successfully. And we just wanted answers. And so we didn't care where we got the answers from. Right. And I think to be honest, post-COVID, that's the approach we need for everything, because COVID is not the only emergency in health in the world.
Yeah.
I think the second thing is, when I was in Cambodia, the New York Times ran these articles about why isn't the pandemic worse in Cambodia? Right? So Cambodia had very low mortality, very high vaccination rates. Cambodia is a relatively poor country, a lower middle income country. And they would have these articles in New York Times about why isn't it worse in Cambodia? And then the really interesting thing was, predictably, they wouldn't talk to anybody in Cambodia. They would just talk to people on the East Coast. They would talk to people in Washington and New York and in Boston. These very smart people who would give their opinions, and often their opinions were quite good, about why it wasn't worse in Cambodia. And I thought that was quite telling. I mean, that's the New York Times, right?
Yeah.
And I think that we have had this presumption. I mean, the US has contributed so much to the world of global health. The US has been the world leader on knowledge for global health. The US has spent the most money on research for global health, both in the US and overseas. Yeah. And that has been a tremendous boon to the world. Nobody can dispute that. However, no one country, even a country as large as the US, has a monopoly on knowledge, right? And I think with the way the world is changing, two things I think are important. Firstly, the pattern of inequality has changed. So before about 1980, if you look at wealth inequality, it was concentrated between countries. Yeah. Since 1980, wealth inequality is concentrated within countries. So if you look at inequality in wealth or inequality in income, more of its contribution is about inequalities within countries than between countries. Yeah. We don't have as good analyses for health. However, the pattern we think is pretty much the same, right? And so what that means is a sort of 60s or 70s model where the institutions in the high-income countries are so much more capable and so much wealthier than the other countries. Well, that no longer holds. We talk about high and middle and low income countries. I used that nomenclature earlier. It's practical. We need something to describe it. But we know those categories are fictions. And in every country now, we have high income people, we have middle income people, and we have low income people. And that applies in some of the richest countries in the world, like the US or Norway. But it also applies in some of the poorest countries in the world. If you go to Liberia, if you go to Sierra Leone, if you go to the Central African Republic, there are people who are of high income status, right? So what that means is that addressing the challenges of people at the lowest income is a common challenge, that challenge of inequality, where we can learn from each other. Because often, even in the richest countries, there are people that are dealing with social determinants that are more similar to poor people in other countries than they are the rest of their own country. So that's the first point. The second point is that a lot of the discussion over recent weeks, as you heard, has been about health sovereignty. And the tolerance for people to fly in from other countries and tell people what to do is lower and lower and lower. And because of recent events, people are saying, no, we know what to do in our countries. We're going to show you what we can do. We have capacity. But what we're interested in is coming together as equals to share knowledge. And on that basis, we're willing to share knowledge, and together we can solve problems. But having a sort of hierarchical relationship between countries, people are very allergic to.
And I have to say, that wasn't tongue in cheek, but I think we had a global health convening here at Wasi a few weeks ago as well. And that was a similar sentiment that whether we like it or not, we are now in a world where it is helpful. Like there's just like more acceptance that I've seen 10 years ago when I moved to the US to understand that other places actually do things and other places do them well, and we can learn from other countries. So I think, yes, we are in a difficult moment for the world, but it seems clear to me also that maybe we're in a more learning space than we used to be. And that's a good time for us to try to think about how do we, as you said, maintain health sovereignty, but also think about non-hierarchical ways of distributing knowledge outputs that we have from different settings. So I really like that perspective. I'm hoping that's where we land, but we'll see. The next 2 years will be interesting.
And you see that dynamic even in the country you're sitting in now, right?
Yeah.
So 20 or 30 years ago, Ivy League institutions had a sort of universal acclaim. And they still have that acclaim, but they face much more challenge now. And for people from different states, I think you're sitting in Missouri. People in Missouri are proud about their ability to generate knowledge and solve their own problems, and perhaps increasingly skeptical about the fact that someone should come from I won't name any specific institutions, but perhaps particularly in the Midwest, that people are going to come from the East Coast or the West Coast and solve their problems for them, right? And more critical of that. So I think it's a similar dynamic, the context. But yet, on the other hand, we're never going to lose the importance of people coming together and sharing their experiences and that need to learn. And so in many ways, addressing these hierarchies, being more inclusive, can be not just more equitable, but more efficient and more effective. And I think that's the exciting opportunity that we face. And hopefully this initiative will not just share actionable knowledge that people can use to change their own environments, improve their health and improve health equity, but also will build networks and ways of sharing that perhaps, if not radical, are at least innovative.
Okay. Innovative might be a better way to frame it. So more people would engage with us on this. I think another thing that we've discussed during the meeting, and I think you've mentioned it multiple times. I don't want to put words in your mouth, so let me know if that's not correct. But you were moved by the approach in Thailand, that the triangle that moves mountains. I've heard you speak about it a lot, and I think that was a big component of thinking about like what can we learn from different settings. So maybe I'm digressing a bit from what we're discussing now, but I just really think it would be helpful for more people to learn about the triangle that moves the mountain. Can you tell us a bit about that? What does that mean? How do you envision that impacting the work that we're doing in this project?
Oh, well, Salma, you're very kindly hitting all my greatest hits, so I appreciate that. I was very fortunate 20 years ago to go to Thailand to document and write up an account of the first National Health Assembly in Thailand with Thai colleagues when I was a young man at WHO, and I got the opportunity to meet many of the senior Thai leaders. And one of the things I learned about and what the assembly aims to embody is the triangle that moves the mountains by Professor Wasi. And I think it's a powerful idea. It says that if you want change, if you want improvement, you need the three corners of the triangle. And so one of the corners of the triangle is knowledge. It's the academics, it's the researchers, but they are necessary but not sufficient. And I think this is something we often forget in the work we do in knowledge generation, because you also need, most importantly, the people. You need the social mobilization to demand change, to advocate for change, to implement change, and also to generate knowledge. And then thirdly, you need power, the politics, the decision makers, the politicians. And that only when the three of them come together that you generate lasting, impactful change. And so the National Health Assembly, which is modeled on the World Health Assembly to a point, brings those three groups. So it brings the government, it brings the academics, but it brings all of society. So from civil society, from activist groups, but also to the private sector. And they deliberate on agenda items. Everyone can propose them. And they deliberate on agenda items, set resolutions to then inform the national policy and implementation. And it's very impressive to sit there and be with all people, not just with the academics or not just with the Ministry of Health people. In a way, it links to Kingdon's sort of models theory and what is required between you need a diagnosis, you need an actionable solution, but you need a window of opportunity, you need a political moment where these can be acted upon. And I think that the caricature of academia in public health or anywhere is that we're too focused on being right. We do research, we prove something, we have the knowledge, and then we get frustrated when no one seems to listen or know or act upon the knowledge. Whereas the triangle sort of captures this dynamic movement of the interaction between different actors. And then I would say the initiative that we are doing with you and with the support of the Robert Wood Johnson Foundation is also to problematize and question who is that corner generating knowledge, and to say, well, actually, it doesn't just have to be the academics. Communities generate knowledge all the time. Decision makers, implementers, we do a lot of so-called embedded implementation research. They're important actors in generating knowledge. So that all three corners of that triangle should be important actors. Co-creating is the jargon, I suppose, knowledge that we can act upon.
So then going back to, since we're now slightly beating up on the academy, not too much. I think we both like the academy,
yes,
but
we do. Some of my best friends are academics.
Just you've said this, but I think part of the conversation about hospitals and universities being conservative is that then there is space now with AI to think about what would they look like in a world that is not too far away from now, maybe 5 years away from now, but clearly a world that looks very differently. So can you tell me a bit about your secret plan to just reshape the university and healthcare?
Well, I feel I have to defend myself a little bit and say some things to reassure my colleagues who work at universities, which is the dominant part of our constituency. Yeah. So as the director of the Alliance for Health Policy and System Research, and it's a wonderful community. And I have worked in a university. I engage every day with people who work in universities. Universities are one of humanity's greatest idea, right? And they've served us so well over the past millennia and more. So I'm not at all beating up on academics. What I think is a little bit like, again, I appreciate that there's an international audience, but with a lot of Americans, the phrase, hate the game, not the player, right? And that we have a chance to reform the system. This is a radical thought, and this is, I think, what we've talking about in the convening. Yeah. University is going to undergo change, and often where the US goes, other countries follow. That's just reality of the size of the US, the influence of the US, how many people have affiliations or funding with US institutions. To realize what I think all of my academic friends, all of my university colleagues want to do, which I've never met a single person in university who doesn't want to generate knowledge that makes a difference and improves the world. That is why people do it. The problem is, like everything, is then when you do the political economy analysis, what are the incentives and the interests in our institutions and in our system, in the game, that mitigate against us realizing this? And this is not something that researchers or academics or universities can solve by themselves. People do the work with goodwill, with incredible effort and sacrifice. And yet some of the challenges to translate this knowledge are beyond the university, right? So if we are a time of tremendous rupture and change, which has tremendous negative consequences, I mean, it's a tough time in the world. Inequalities are getting worse. Health is getting worse in some places, which is not something we would have said for a long time. There are tremendous challenges in both communicable and non-communicable diseases and social determinants. But the university is under attack and under challenge in many ways, right? So if things are going to change, and they are going to change, can we be optimistic, half glass full, and use this change to address and transform some of those gaps we've identified in our practice, right? And I think that's the question. And so AI could be one of those enablers. And of course, we feel very concerned about AI. There's a lot of concern. Is AI going to just replace humans? So we're doing some work, as you know, on the role of artificial intelligence in health policy and systems research. Many people are working with us on this, and we'll have a report, but we'll also have a live sort of toolbox and community practice. And really, it's trying to see, well, what is the appropriate use of AI for research? It's already happening. Often it's a bit covert. People feel a bit embarrassed or a bit stigmatized about it. Yeah. It's changing so rapidly, what's possible. But I do think that AI is going to accelerate this transformation of academia, right? I think universities are going to look very different. And what we're saying is linked to our previous conversation today, that AI can be an important tool in democratizing our research methods, our research approaches. Already, for example, essentially you can do a systematic review using AI, and it won't necessarily be worse than your average human AI. We have to be very careful that
it will just be much faster
and much cheaper and much more interest. It's a little bit like, well, you probably don't remember, but I remember when I first used SAS, right, to do a logistic regression. And I just thought about, wow, semicolons and colons notwithstanding, and when you program, it wasn't as user-friendly as it is now. But it was just so powerful. Did I regret that I could do this much more quickly than previously? Of course not, right? Yeah. And so, but AI is harder than that because it's not just a dumb tool. The idea is that AI can learn for itself, and that is challenging for us, right? So then the question becomes, what can AI do, and how do we steer that against the risks of inequity, proprietary capture, lack of privacy, poor quality data, disinformation, to leverage that ability for it to democratize, make things more accessible. But how do we preserve what is still intrinsically human that has to be done by humans? And how do we then prioritize our human time, our human resources for those tasks? And then how do we integrate AI into teams? right, of researchers. How do we make agentic AI be part of a research team? We have a lot of experience of doing that with people, right? But we need to think about that. And I do think that that will mean that communities, that policymakers won't go to the academy for certain things, right? I mean, we have often struggled to get academics to find the time to write policy briefs, for example. Well, now there's no excuse. I mean, you can put it in an LLM and say, please, here's some examples. Here's my paper. Here's my report. Do that. Do me a YouTube video for 1 minute with my key messages. But there's going to be a lot more than that. And I think for overwhelmed people in ministries of health who are always seeking evidence and knowledge, but often find it very hard to find it. There are fences. There's not everything is open access or grey literature you can't find. That they will now be able to synthesize much more effectively. And I've talked to ministers and people in ministries who are already doing that. And so then the question becomes, as it should be, if some of that sort of work is no longer needed from academics, what then should we be focusing on in the academy? And that's very exciting, right?
Yeah. Well, Kumanan, before we end, I just wanted to ask you about, so you just described a world where AI is going to change things drastically. I think I agree with that assessment. Of course, there are going to be consequences, but I think things are going to change. I've seen an AI agent a few weeks ago retrieve about 76,000 papers overnight. So I think the world is going to change. So knowing that we're going through a time of people rethinking global health infrastructure and thinking about reform, living in a world where universities seems to be challenged on being the arbiter of knowledge or entities that provide enough social capital for the world to continue to invest in them. How is this initiative going to contribute to that world? In 2 years from now, looking back, how have we contributed? I know this is not what we signed up for when we started envisioning this a few years ago. That's not where we were. But I think the moment requires us thinking now, what can we do that is useful in a world that is changing drastically? So 2 years from now, we're having a conversation, or 3 years from now, we're having a conversation. What have we done that was useful, that moves the conversation forward?
I think that's always the question. And what I encourage my team whenever we do anything is to really start with thinking, well, what impact do we aspire to? Yeah. And that impact isn't the papers we write or the reportments we release or the meetings we have. And I do think we need, in this world, to justify our existence. So this is a good thing, that we don't just assume what we're doing is useful of itself, that we really push ourselves to say, what change are we contributing to? Because many of us operate with a certain level of privilege, and these resources are going to be increasingly under challenge. And as public health community, as a research community, we've done many good things, but clearly there's room for improvement, and I'm optimistic. And so firstly, I hope this initiative contributes meaningfully to that thinking, for thinking how we change knowledge generation, for thinking how the public health community considers itself the global health community, and how researchers see their role in knowledge generation that is useful to improve health equity, right? I think we should reflect that even the phrase health equity has become contested, and think about, well, why is that? Is that purely ideological, or is there some aspects of our practice that perhaps we could have done better? And I think, like most things in life, the answer is both. Right. And so there are some things we could change that we can't change, but we can change the way we practice. Right. And so I hope we contribute to this. I'm very much not a techno-utopian. I think there are real concerns and risks about AI, and clearly those concerns are shared by the Pope. And I think the encyclical that has recently come out, this is really going to test humanity. And the question is, can we steer it towards equity, or will it, like often happens with technology, exacerbate inequity? And that is going to be a fundamental challenge of our time. And so I hope the initiative itself engages us with questions of AI and provides some meaningful insights that can be useful. We are this first generation thinking about AI. That's an exciting place to be, but it provides a great responsibility to get it right, because there will be a path dependency to the interventions, the policies, the decisions we make now, that if we don't get them right now, we'll spend the next 10, 20, 100, 1,000 years trying to fix. And I'm not suggesting a matrix-like scenario, but I'm just saying that we need to get it right now. And so I hope the initiative contribute to that. More concretely, I hope that the initiative proves the concept. And I'm not saying we're the first people to suggest that you can have global learning between the US and the rest of the world. We're certainly not, right?
Yeah.
Americans are curious, open people. But as you say, this is not the usual practice. So I hope that the American colleagues who participate can say, we can point to, here's some things we learned that we can apply in the US. And then, of course, our particular mandate is, I hope that by this work, all of the groups involved are able to document what they do and their interventions and sort of test them. And this can occur in a way that potentiates their work so they become more effective in implementing interventions and policies that improve health equity, and that they also feel more confident to share. And for the community groups, that they feel a legitimacy they have that legitimacy, but often they don't see themselves engaging with academics or universities. And so they have an increased sense of their own agency and potential to generate knowledge and drive change. And they see that as something that they don't have to defend or apologize for. This is just something they do, and that in this world, they can play a greater role in. I hope that in each of the groups, whether in the US or in other countries, we build networks which, beyond this initiative, then allow for that co-creation, that triangle that moves the mountain, and for people to continue working together. I've seen this throughout my career. It is about relationships. And I think this initiative is well placed. And then finally, I hope the initiative comes up with some insights for the academy and the university of the future, which is already here, and can make its own contribution to steering that, as I said, to keep the value of what we have, but also to overcome some of the gaps. And of course, I hope that it's of value to American universities, but I hope for many of our universities in low and middle income countries, which are really fragile at the moment with the sudden drops in funding, which we wrote about recently in the Lancet, as you know. I hope this also gives them some ideas about how they can progress, be more efficient, where they should prioritize their investments to build capacity, and also, again, gives them visibility, creates networks, and helps them to be more successful in working in their countries, and also attracting resources to do this very important work on improving health equity.
Kumanan, thank you so much for joining us today.
Thanks so much, Salma. As always, a pleasure.
This episode was edited by Catalina Melendez-Contreras, with marketing by Kinkini Bahadri. Complicating the Narrative is supported by the Wasi Pursky School of Public Health. And this miniseries is part of the Building Better Ways of Knowing project, funded by the Robert Wood Johnson Foundation. If this conversation was useful to you, please pass it along to a colleague who cares about the future of public health. Thank you for listening.